video off.
All right, welcome everyone on this NOS clinical meeting. And this is Phaco Panorama. And we are really privileged to have Dr. Titial as the keynote speaker. And he'll be speaking on Phaco in difficult situations, followed by Dr. Gaurav on panoptics. And Dr. Saurabh will be taking us back to the basics of Phaco. And Dr. Tiwari will be speaking on how to tackle those Argentinian plaque sign. And of course, our Dr. Ritu, she will be speaking on the new modalities of this new panoptics, vivinity, and newer multifocal IOLs. So I hand over to Dr. Ajay I know Dr. Titial doesn't need any introduction, but formally, I would like Dr. Arora to introduce him.
Thank you, Dr. Atul. So this is the 5th webinar of the Non-Ophthalmic Society, and we are highly privileged to have Professor Titial, whom I've known for years together. You know, I first met him almost 30 years back when I was an assistant professor at Aligarh, and I had come for a keratoplasty workshop. And that is the first time I met Dr. Titial. I have known Professor Titial for so many years. And if I can say that if you are an Indian ophthalmologist and you do not know Dr. Titial, you cannot be called an Indian ophthalmologist. He's so very well known. So he's the senior most professor in Indian Institute of Medical Sciences. Sir has done a lot of work on cataract, cornea, pediatric cataract. He was the first person to do the live corneal transplant surgery amongst the Indian surgeons. He was the first surgeon to do a cataract surgery in the American Academy of Ophthalmology live. He is the person who has operated on our ex-Prime Minister Manmohan Singh, the Dalai Lama, Chief Minister Sheila Dikshit, and many more. You know, there's an empty list. And he has over 300 publications in the peer-reviewed journals. He has achieved innumerable awards that if I list them, I'll probably finish in 2 hours of this entire symposium. So I'll cut it short just to say that he has been awarded the Padma Shri in 2014. Welcome, sir. It's an honor for you to be here with us, and we welcome you all. I would request you to share your screen and start the meeting. And thank you, Gaurav, for being here. I will take the opportunity to introduce you once we have heard Dr. Titial. Thanks, sir.
Thank you, Ajay, for a nice introduction. Absolutely delighted to be amongst dear friends, starting from Dr. Atul, Ritu, Ajay, and Saurav. I think BK will join us subsequently. Gaurav there, and it's my pleasure to be amongst the friends today. And I think Ajay is right. We have been known for a very long time. The initial one of the the memory I have is traveling to Ahmedabad, the AIOS conference, having a tough time going to the railways, those older days. Let me share my screen today. I think it is very important to discuss cataract because that is the bread and butter of all of us. And let me just okay. No financial disclosure from my side. I think to begin with, let me start with my own area of interest, that is cornea. So it is very important to discuss endothelial dystrophies or cases with compromised endothelium. In cataract surgery, we do all know sometimes you do damage the endothelium, especially in those cases where you have a compromised endothelial function like Fuchs, because this is the age group where you can have cataract and endothelial dysfunction together. Three important aspects in a Fuchs patient. One is corneal thickness. Second is the quality and the type of cells you see in these cases. And third is the cataract, which may be significant or insignificant. Depending on that, you can decide triple or a cataract surgery first. I would say if you have a thickness less than 650, you might jump for cataract surgery alone. For saving the endothelium, we like to do a triple soft cell technique. This is the case of the Fuchs endothelial dystrophy. So first we make a clear corneal incision, good dilatation is requirement. I'll be injecting dispersive viscoelastic first, that is Biscote from Alcon. Subsequently, to push this dispersive towards the endothelium so that it coats the endothelium throughout the surgery. Inject cohesive viscoelastic subsequently, 1% sodium hyaluronate. This will take the entire viscose coating to the endothelium, especially the central area, which is the area of interest for us. Then inject little bit of a BSS underneath the cohesive viscoelastic to have a space for doing a rhexis, because otherwise the flap turning and rotation can be difficult in these cases. So this is triple soft shell technique described by Ashenov, which is really useful in cases where you think your endothelium is compromised. You can see how nicely I could lift the flap because I have a space between cohesive as well as dispersive in these cases. Sometimes if you just inject dispersive viscoelastic, things can be very difficult in terms of rotation of flap. And if you inject dispersive first, it also sort of delineates the subcapsular epithelium which is there in these. You can see it's like a stained capsule, and that is also beneficial in cases of little compromised hazy cornea also. So dispersive viscoelastic is a good feature in this regard also. This is a wave of fluid to create a hydrodissection. Rotation is simpler. So advantage here is the Biscote coating is there till the end and protects it. Though there will be a little bit of discussion, the removal of dispersive viscoelastic towards the end can cause take more time and may cause endothelial dysfunction, but it doesn't happen. You don't have to remove the entire dispersive in that manner. So once we're done in the bag Phaco, you can see I've implanted the Acrysoft IQ lens in this patient. You can see a nice staining of an anterior capsule. But this staining also helps you for a delineation of a rhexis margin during your surgery as well as after implantation. Or sometimes if you want to do a epithelial, you can say polishing of capsule, it also gives you a very nice delineation. So that is what is protection of endothelium in case of a compromised endothelial surgery. I would also prefer doing a femtosecond laser because in these cases we know that there's a definite decrease in our Phaco power and Phaco time. This is our study published where we compared grade 4 nucleus with two types of nucleotomy pattern in femtosecond, and we realized that if you do a matrix pattern, there's a very significant decrease in endothelial cell damage in these cases. In Fuchs patient, because you have a hazy cornea and peripheral attachment can be little loose in these cases, so you can have decimal detachment happening much more open. This is I had completed the Phaco. I've injected the IOL doing irrigation aspiration. At this stage, you may not be able to see the detachment happening in these cases. So sometimes when you actually do the stromal hydration, you can see the endothelial guttae can be nicely visible in high magnification here. So it is important to do an assessment of your hydration. See, I'm doing hydration here. And if I do hydration and if not careful, then you might miss it. We have IOCT here. You can see the large detachment or decimal visible there. So such cases, if you don't assess carefully under the microscope, you might miss this detachment. So anything detachment which gives more than incision side, almost 1 millimeter inside, you may have to intervene on the table by injecting air or a gas to cause a temper. You can see how large is detachment here. So this detachment you can see in the right hand side OCT picture can be taken care by injecting air like we do for a DSEC or DMEC patient. Keep the air bubble tight for at least 3 to 5 minutes so that this detachment attaches. So this is learning for all of us. You should be careful in our own management of a Fuchs patient also subsequently. So these are points which you normally remember: soft shell technique for endothelial protection, in the bag Phaco, and look for a wound side DMD in these cases, especially post-op patient. If you have a uncomplicated cataract surgery and you see cornea is hazy, you must do an anti-segment OCT to rule out desmoid membrane detachment in all these cases with compromised cornea. A little bit on a small pupil Phaco or of intraoperative floppy iris syndrome. The management we all know is basically looking for a pharmacological agents. Pre-op, it is very important to use NSAIDs along with the mediatic drops, which will maintain the dilatation throughout your surgery, and some intra-op manipulation which may be required. This is a very recent publication comparing the once daily dose from the BD dose or bromphenic, and we realize the aqueous concentration of a single dose is almost equal to twice a day dosing, and it should be used at least 1 or 2 days before to have a concentration active in these cases. This is a little bit of sign which I normally tell my resident doctor. If you have a little flutter, that means your pupillary dilatation not sufficient, and the amount of flutter in the iris or pupillary margin tells you how would this pupil behave subsequently. You can see now I'm trying to inject the viscoelastic. See this flutter here. So this flutter is or a pupil getting little oval, or sometimes if you have a large floppiness, the iris tissue will come to the wound area. So this patient requires a management intraoperatively by either injecting adrenaline intracamerally, which I'm doing under the viscoelastic cover. The pupil dilates nicely and you can complete the surgery in these cases. This is another case where the pupil remains static. So these are rigid pupils where dilatation would be maintained throughout your procedure. Despite having a small pupil, you can still do a routine phaco surgery in these cases. So there's not much of flutter when I'm trying to inject viscoelastic here. A little bit of dilatation which will happen with the high viscosity viscoelastic substance. You can combine dispersive and cohesive to maintain the viscosity of viscoelastic throughout your procedure. So this pupil is around 3.5 millimeter. The rhexis has to be a little bigger. So we may have to initiate the rhexis slightly underneath the pupillary margin. Make sure if you're not seeing clearly, stay in your capsule. And if your rotation is not happening properly, you must use an expanded device at this stage so that your rhexis remains circular and complete. So this is the learning in a small pupil. Make sure your rotation is simpler and as you desire. And if needed, you can inject viscoelastic to still dilate the pupil at that stage. I think hydrodissection is mandatory properly in these cases, but unfortunately, most cases, because you're not seeing the rhexis margin, your hydrodissection may not be complete. So your technique has to be a little modified in these cases. So this is the hydrodissection I'm trying. The pupil, I'm trying to release the fluid, but the rotation is not complete and you can't do. In fact, I would suggest bimanual rotation at this stage so that your pupil can rotate better. So I'll be doing phaco now because parameter is normal. Around 55 is my IOP, which is a slightly older video. Now I have shifted to 40 IOP in most surgeries, and moderate parameter or aspiration flow rate and vacuum. And subsequently, what I'll do a first chop after making initial groove so that I can go deeper. So once you hold this nucleus, make sure your initial chop goes little deeper. So that will be maintained by little space here to create here. You can see I've made one chop here. The rotation is not possible because hydrodissections are not complete. You can see at this stage, take out a small pipe. So this one quadratic chop will give you a space for a subsequent chopping, and the fluid might seep in to create an internal hydrodelineation at this stage. And subsequent rotation can be easier. You can see again the rotation is not happening completely. I'll take out one more chop from here. So your volume of nucleus decreases. So you can in fact rotate, or you can catapult this piece of a nucleus subsequently. Now I have a half nucleus without rotation. This is how we manage where you don't have a proper hydro procedures. Or in those cases like a posterior polar where you don't do hydrodissection, the things can be difficult. Now you can see the nucleus can be now rotated. and chopped. So this is the internal hydrodelineation which has happened. Subsequent chopping can be easier. You can see I have taken out that. The next difficult part is taking out the epicortical cushion, which is normally large in these small pupil cases. There you have to be very careful. Use eye probe so that you can take out the entire epicortex. If possible, you can use bimanual irrigation aspiration to go underneath the small pupil and take out the entire cortex in these cases. If you're using a toric IOL where you can't see the peripheral margins, even at this stage, you might have to use the iris hooks at this stage also. So that is important to understand. Now let me shift to a little floppy iris. You can see I have the pupil is reasonably well dilated. You can see the floppiness here. Once the iris pupil is peeking towards your side port or towards your main port, that indicates the grade 2 or more of a floppy iris. So I would inject a dispersive viscoelastic bolus here, which will push the entire iris backwards. And this dispersive viscoelastic will not leak out. You can see how nicely the pupil dilated. I could complete the surgery without difficulties. In some cases where you have, like this is a reasonable sized pupil, I could do a basic procedure after injecting a little bit of adrenaline. Such cases, if you know the history of a patient, male patient in a BPH treatment, you can use atropine preoperatively also, which is recommended apart from the NSAID. I could do a rhexis. You can see the pupil is not very rigid. So these cases, I understand, will definitely, the pupil will become smaller as we go inside. So this is after injection of adrenaline, the pupil still is little hazier. So this is a stage where you might think you may have to use expander. So you have two devices. You can do a rings or you can use a hooks. Hooks for us is much simpler. See this pupil which is getting towards the wound area, making things difficult. So I've done a dissection here and the pupil is coming here. So this case I'll not do further. The best is to do a peripheral incisions which is slightly posterior to the limbus so that tenting or iris is avoided when actually doing the hooks placement. So we normally create a diamond shape. So you have 4 hooks or sometimes you can use more hooks also depending on the size and difficulty of pupil size. So this is what we do. If these hooks sometimes are longer and a small pulpal aperture, they might hit the, these margins. So you can cut also to make it smaller. So this is a small pupil. I could do a phaco nicely. The pupil is maintained and subsequent phaco can be completed very nicely with the proper rotation and implantation IOL. Don't stretch pupil too large because that is not needed. So this is the area which requires a more visibility. You can use little more force here. Subsequent to placement, before you remove the viscoelastic, you must take out the iris hooks. So I'll just rotate and take it out. And don't be in a hurry to take out all of them together. Make sure things are comfortable and visible. So once I do it under viscoelastic, chamber is well maintained and subsequent damage or manipulation is less to the pupillary margin. You can see this is towards the end of surgery. I do a bimanual aspiration. Suturing of a main wound is must because if you do eye from here, the pupil will get distorted and you'll have more damage to this area. And subsequent post-op period, after a few months, you'll have a large atrophic area. So that should be avoided in these cases. So this is what I explained, various tips for a small pupil. Little bit on a subluxated cataract. This is how we normally go. Any case which is less than 3 to 6 clock hours, we can do a routine phaco. And this is a small video I would like to share with you people. So this is a case where I have almost 4 to 5 clock hours of subluxation. So we can try femtosecond laser, which we have tried in many cases with a good results. And because that has the advantage of a pre-cut capsule and fragmentation. These are 2 types of hooks which are normally used. As I said, in a small pupil also, you can see here, if you do a pre-limbal incisions, you'll have a tenting of entire capsular margin. So you can tear the capsule in these difficult cases. Always go a little posterior so that you are parallel to the iris plane. The tenting of a capsule will be decreased in these cases. So this is what you'll see in this patient. I'll make one posterior. You can see bleeding means I am posterior to the limbus. And this will not have a tenting effect onto the rexis, which we'll be doing in this case. Staining of entry capsule is must so that you can visualize the entire rexis in these cases. Do a rexis little paracenter because this is the area subluxated. Don't go to periphery. Otherwise, you can either have a very irregular rexis, or you can be difficult to do hooking this capsular margin. Once I stabilize the entire capsular bag, I can do a routine Phaco. I normally don't put CTR at this stage because sometimes it's very difficult to adjust CTR in these cases. You can see these eye hooks keep hitting the margins, and that can damage the rexis margin. So I have cut this hook so that it doesn't hit the margins also. So you can trim this distal end of hooks that see I'm doing here, so that my capsule is not hit by this jerk which is happening during my Phaco procedure here. So the reasonably hard nucleus. Once you do a chop here, make sure your dynamics are such so it doesn't cause too much of fluctuation anterior chamber, because the capsular bag may be little floppy in all subluxury cataract. I have removed the entire nucleus. Then I'll put a CTR, which is normally 11-13 size in adult cases. Then I'll remove my hooks to see if my bag is stable. If the bag is quite stable, then I'll do implantation. You can stain this with transnolone and do a little vitrectomy. See, if your bag is not centered well, then you may have to do a fixation in these cases. Subluxated in cases, sometimes I prefer femtosecond laser because it has the advantage of doing a capsulotomy before opening the limbus. If you open the limbus, subluxation can increase, vitreous can come in, and pre-fragmented nucleotomy is also there, which also prevents the damage happening during that step. If there's a vitreous, then pre-capsulotomy with femtosecond is advantageous in these cases. So this is one patient. Briefly, I'll show this how we manage this patient. So if you see the OCT of this picture, which tells you the entire picture, so I'll shift my capsulotomy away from my subluxated area. And this is the capsular adjustment. And you see here, this is the lens, and this is the large vitreous bolus which is there in antechamber. So even you have a vitreous, you can nicely do a capsulotomy. You can see capsulotomy here. Because of vitreous, you can see the gel formation here, and nucleotomy being done in this case. So first, we'll do a posterior limbal incision for maintaining the integrity of capsule during Phaco. Remove the capsule. You can make sure that capsule is taken away very nicely by doing a manipulation which normally do as a rexis. And then you can stain the entire antechamber with transnolone, do a vitrectomy so the vitreous is taken away before we initiate the Phaco in these cases. Subsequently, once you do a complete, without doing hydro, you can do a complete nucleotomy in these cases. As you saw in a routine Phaco, here also I completed my Phaco, aspiration by bimanual here. Then put a CTR to maintain the bag, and subsequently I'll put IOL. After putting IOL, put a suture in the main wound area. Again, put transnolone because vitreous may still be there in these cases. You can see a little bit of stand here. Complete the vitrectomy, and that will complete the procedure also. So both manual and femtosecond can be done. Femtosecond does have an advantage of before opening, you can do a very important steps also. Post-op also very important. Some cases maybe because of trauma, so you have to look for angle, IOP, macular OCT, and regular follow-up is required for these patients. Little bit on a white cataract that you all know. This is later covered by Dr. B.K. Tiwari. This is the one case which I got from Dr. Namrata Sharma. You can see as soon as we initiate, the entire tear goes to the Argentinian flap, and things will become very difficult. So this is another case, like you can see the capsule is pouting. We didn't have an IOCT at that time. You can see as soon as I make a nick here, it seems to go to periphery here. So what to do at this stage? So I'll make a cruciate incision so that your forces are transmitted into 4 directions. So this is one. So this will decrease the pressure going to periphery, and subsequently use dispersive viscoelastic to cover the peripheral area. Then I can make a little bit of not circular, but you can see the tear is still extending here. I'll just take this faucet and try to nudge it out, then do it from other side, and hope that the tear doesn't go to periphery. So if you inject a dispersive viscoelastic here, it doesn't come out. it maintains the pressure here. Subsequently, I'll take this tear beyond the tearing margin and the things are complete here. But we know that if you do a pre-op examination carefully with slit lamp or anti-circumventing OCT, you can pick up those cases where you can have a raised intraventricular pressure like this. And same thing would be with IOCT also, which we have classified in our various types of wide cataracts. Type 2 is the one which is very difficult case where the pressure doesn't get released even after capsulotomy also. Type 1 is simpler. Type 2, I like to highlight here. You can see as soon as I make a capsulotomy, nothing leaks out. The cortical fibers, they bulge out like a mountain or like a hill, and it still has a tendency for a tear to extend in these cases. Such cases, you have to do a bimanual aspiration after doing the initial incision here. And simple needle aspiration may not work in such cases. You can see this hill has to be taken out with a bimanual aspiration here. So I'll inject little bit of dispersion in the periphery, then try to make a small opening here. This is a 1.5 millimeter. Then take out entire cortex which is hydrated and see the flattening happening, convexity coming back like this. And subsequent rexes can be easier now. And that's the policy we should follow for all cases with raised lenticular pressure. And subsequent phaco can be simpler in these cases. Type 3 is a combination of fibers and fluid. Normally after making a nick, the fluid leaks out like this and surgery becomes simpler in these cases. Type 4 is like a Morganian cataract. Entire capsular bag is filled with a milky fluid. As soon as you make a nick, the fluid leaks out and then pressure goes down. Rexes become simpler in these cases. But make sure you don't have too much of a loose bag in these cases. You may have to still fill the bag with a viscoelastic sometimes to complete your rexes in these cases. Femtosecond is totally different, exactly opposite of a manual rexes here. So this is a case where it's like a type 3, type 4. You can see here fluid as well as the fibers here. As soon as you make a capsulotomy initiation in these cases, the entire area is, they come out like a burst of milky fluid. So this can cause a lot of micro adhesions. While in manual rexes, this case becomes simpler. Posterior polar, I think you all have seen my videos earlier, just to show this general case after doing the good rexes, which is around 4.5 to 5 millimeter. We'll do a hydro delineation only. Hydro dissection is avoided in most cases. Just to highlight, this is a delineation being done. Subsequently, moderate parameter, you can take out the nucleus. And no rotation should be done in these cases, just tapping from the side so that the fluid comes out. And subsequently, you can do a sculpt or a chop depending on the hardness of nucleus. I'll take another 5 minutes, Ajay, just to take out this layer by layer, which is a classical description. And then subsequently take out this epicortex slowly, peel from the periphery and leave to the center. Peel from the periphery, leave to the center. So this is what you can see a defect which is seen, which we have described recently in a JCRS as a posterior polar cortical disc defect, PPCDD, which is a sign of a safety in fact, in a posterior polar cataract. So you can complete the surgery subsequently by taking away the epicortex. You can do it with a handpiece if your machine is well under your control, or you can do a bimanual aspiration to take out the entire cortical fibers and implant ion subsequently. So this is what we call PPCDD, that is a posterior polar cortical disc defect, which is normally seen after a completion of nucleotomy or after the aspiration of epicortex. These are normally seen in almost more than 86% of the cases. And in these cases, the chances of posterior capsular rupture or dehiscence is 0. But if you don't see the sign here, like this patient, we didn't say a sign, that means the disc is attached to the posterior capsule very densely, and chances of tear happening in these cases are little higher. That means almost 44% of cases you may have a tear coming up in those cases where you don't have this disc defect. So that is important to realize that if you have a disc defect, the chances of this capsule getting deficient is less. You can see here, after completion, I'm trying to take out epicortex here. So this is a defect you can see. If you're not understood, you might feel you already have a defect here. But OCT gives you a clear indication that posterior capsule is intact in these cases. And subsequently, you can do a procedure here. This is our way of classifying posterior polar cataract, and this is our technique of doing in a femtosecond way, which also gives a good assessment intraoperatively, as well as you can frame the nucleotomy so that you can do a layer by layer phaco in these cases also. Very few, one or two more videos to show. This is pseudo exploration. You can see a large area of pseudo exploration here. Only to highlight here is surgery is simpler. Rexis should be complete and should be more than 5 millimeter, because chances of phimosis are very high in these cases. If you do a 3.5 millimeter or 4 millimeter, phimosis can happen. But after do a good nucleotomy, normally I would like to put CTR in all these cases. See, I have completed my aspiration here. CTR, I'm not sure because we don't have a long-term follow-up, but those cases where we put CTR, maybe chances of bag contraction also less. And subsequent bag dislocation may also decrease in these cases. Even you have a dislocation, sometimes you can fix this entire bag because your CTR in this case. That is the only thing I would like to highlight. If a small pupil, you can always use the expander in these cases so that you don't cause more damage in these cases. RK, I would say it is important to assess the incision, amount of incision, and the optical zone is important because you may have to take pentacam for a calculation in these patients for center 3 millimeter. The incision has to be posterior limbus here so that, this supports your incision, which is because these are smaller than the 2.2 millimeter. There are at least 3 incisions coming into my incision of 2.2. And subsequently, you might have to assess the entire incision. Rexis has to be good. Intraocular protection is required. The calculation has to be done either with Haig's or Barrett's formula in these cases. Make sure if you have a difficulty aspiration subcortical, use bimanual so that you don't distort your main incision in these cases. Even if you have a little bit of a normal looking incision here also, I'll never hydrate my RK wound. Always put a suture in the main wound and try to build pressure from the side port in these cases. So my incision is absolutely correct. The incision had not opened up. But if you have an opening incision, you can put a shoelace type of suture in a wound area in these cases. This is a small trick which can happen in a hard cataracts. Even with those cases like this, I thought I'll complete my Phaco, but there was little difficulty and then the Phaco power had gone too high and posterior capsule little floppy in these cases. I injected the IUL first to give a scaffold to a posterior capsule, which can be used in a PCR also. Take this piece of the hard nuclear center and you can Phaco this over the IUL without risk. White cataract I've covered. This is the Morganian cataract where I think Rexis becomes very difficult sometimes because the nucleus keeps moving and support from behind is very less. So I have initiated, you can see the little tear going not in my way. Here also is not going because the posterior pressure and anterior pressure should be such which gives a good tearing of anterior capsule. So I'm doing a gentle rotation so that I don't go too peripherally here. And subsequently, I think the better would be to use a micro forceps or a Rexis forceps at this stage and try to do a good Rexis here. So this needle, I have a nice hold of a capsule. It can be rotated like you do it for a forceps. Large rotation can be possible if you feel you are in a comfort zone. I'm pushing the nucleus to that side so that I have a support here. So that is very important learning here. Nucleus can rotate either side. But make sure you have a larger support from behind. See, I'm again trying to push my nucleus to area, which I'm doing a Rexis. If needed, I might inject little bit of viscoelastic to support from behind and complete my Rexis. And nucleus management is much difficult in these cases. You have to hold in this middle with a deep burst of Phaco. So once you have a good hole, you can chop it from the periphery like you do a Nagahara chop in these cases. See, the entire nucleus is free in this case, so very difficult. I'll go deep here, as deep as possible, and pull the nucleus to your side. Make sure you have a good hole first. So once I have a good hole, I'll go to periphery and chop here. Again, I'll go here, hold it very tight and deep, then go pull the nucleus so you reach the periphery, then chop it here. In this way, you can manage these free floating nucleus also, which is sometimes very difficult because the bag also can be loose. You can cause a bag dialysis if you have a smaller Rexis here. This still can also damage the peripheral bag jonules, and subluxation or a bag decentration can happen in these cases. So in such cases also, even a little doubt of bag being little loose, I'll put CTR after completing my nucleotomy in these cases. Because all these hypermature cases, the bag can be little, loose. Sometimes the journals may not be visibly support the entire bag in this case. So this is a completion here. Then subsequently you can inject IUL in. I would like to again thank the Noida Ophthalmic Society for giving me this opportunity to be with them, and enjoyed being with you, Ajay.
Thank you, sir. Thank you very much. I think all the cataract surgeons would have, I learned a lot being a retina surgeon. I think the cataract surgeon would have picked up a lot actually. There were so many practical points at every step. Yes, Dr. Atul, I think we should welcome Professor Jawaharlal Goel. He has joined us, and Dr. Neetu Sharma. Dr. Neetu, so I give it to you, Dr. Atul Singh and Professor Goel, to take over.
Yeah, Dr. Titial, you have made these complications look so easy in your hands. I mean, we were totally mesmerized with your presentation. And
I think Atul, there is one question from Dr. Ritu regarding use of YAG laser for doing in a wide cataract capsulotomy. I think that can also be tried. Many people tried this also. And we used to do quite a long time back in the 90s. We used to do YAG laser when we didn't have a good concept of doing a capsular access in a wide cataract. Because we started Phaco without understanding capsular access in those days. So we used to do YAG capsulotomy, and in wide cataract, especially in cases where you have a more of a fluid type of capsule, YAG laser does help, but you have to take the patient immediately to the OR within half an hour or so. Otherwise, this leaky material can cause glaucoma, inflammation subsequently. But if you have, as I showed, two slides, one is slit lamp examination and one is the anti-segment OCT. That will tell which type of cases you should do a YAG, or which type of cases you will do a needle aspiration, and which type of cases you have to do a bimanual aspiration. So that would be decided by your clinical examination. You don't require an IOCT microscope, but if you have a good slit lamp assessment, as well as anti-segment OCT will delineate, all these cases.
One question I wanted to ask you, Dr. Titial, do you vary the wattle heights in these different complicated situations?
Yes, we do, especially in cases with posterior polar subluxated cases. And you need to keep a moderate bottle height if you're using the gravity assisted fluidics. Normally people keep 100, sometimes people have seen 110 also. You should come down to around 80-90 bottle height in these cases, because I use the Centurion. So normally my IOP is for standard cases 50 nowadays. If I see my cases with posterior polar or a patient with a little subluxation, my IOP comes down to 40, and that makes things easier. The case I showed is the floppy iris syndrome, because if you have too much of fluidics there, your iris pupil gets little distorted to begin with. There also the IOP has to be low. Similarly, your aspiration flow rate and the vacuum which you have also should be titrated according to your bottle height which you have decreased. You can't keep the same bottle height as 110. It has to come down. The aspiration flow rate should also come down a little bit to adjust your entire fluidics in the anterior chamber. So in floppy iris syndrome, in posterior polar, where you feel your capsule may be open, in those cases where your capsulotomy was not complete, your axis is gone periphery, it's torn in the periphery, there I think the slow motion Phaco or a low moderate parameter should be kept in these cases.
Right. And you were discussing the stuck nucleus which was not rotating in the small pupil. Can we redelineate or rehydrate? Because in some cases I've seen it.
You can. Atul nicely pointed out, because this is a technique which people have not described in the book. It's very soon going to come in a publication from our side. How to manage those cases where you are not allowed to do a hydrodissection or your delineation not complete, especially in a posterior polar cataracts, or a patient where you have already, a damaged posterior capsule, like a post-BR surgery, posterior capsule damage, or a subluxury cataract, you don't want to rotate the nucleus. There, this trick is very useful. Once you have to do a bisection of nucleus, which may not be complete in these cases, even you have a half bisection, that gives a space for a subsequent pi of a nucleus to be taken away. So we do a multiple pi, at least 3 pi's can be taken out. That will give you almost 45 degrees either side, and that will definitely give us space for a fluid to seep in into the epinuclear area, and you'll have an internal hydrodelineation happening in these cases. But you are right. If you feel your case is not, despite the initial chalk, the nucleus is absolutely tight, then you should use a little viscoelastic over the from the side port. Take out your handpiece away, then go from the side port to create a little hydro dissection or delineation from a superior side. Inferiorly, you have already made a pi. So superiorly, you can inject a fluid, and you again can try that, and you might succeed because now the space is there. Initially, the large nucleus will not allow the fluid to seep in. Now, subsequently, you can do a re-internal hydrodelineation with your cannula also. People do it. People also do it the hydro, not with the hydro. They can do a viscoelastic also. Injected disperser, which is much more fluidic and seeps in very nicely. Don't use a cohesive viscoelastic for a delineation. Use disperser. You can use methyl cellulose also, which is like a dispersive viscoelastic. People do that also. When you're using viscoelastic, then do it from the main port, so that you don't build up pressure too much. If you're doing a hydro procedure, you can do it from the side port also with a little bit of fluid.
My last question was, in the post-RK patients where you're doing the Phaco, you said that you should go posterior limbal. Is there any problem we go a little scleral by injecting a little bit of subconj Xylocar?
No issue at all. You can put a little bit of Jalokin there to make things simpler, but I don't do that because if you're doing a 2.2, 2.6 incision, the patient normally doesn't feel anything. So you can directly go in, but there'll be a little bulb of conjunctiva happening towards the end of surgery. If there is bulge of conjunctiva happening, because there's not much of tenon in the temporal side, because I do surgery from a temporal side. So this bulge is never big. If you're doing a superior side, the entire conjunctiva ballooning is very fast. So there, if there's a little bit of conjunctival balloon, I make a 2 nicks in the conjunctiva. That will immediately take away the fluid away from the the conjunctival side. So you can easily do a surgery in these cases.
Very useful tips, sir. Thank you so much. It was so illuminating.
Yeah, most
and I'm sure everybody has learned so much from this. So now
thank you.
Thank you, sir. Thank you very much. So now we welcome our next speaker, Dr. Gaurav Mishra. He'll be speaking on trifocals, and I will ask Dr. Arora to introduce Dr. Gaurav.
Before I introduce Gaurav, any more questions Dr. Neetu has or Professor Goel has? You can ask after Gaurav's talk. Dr. Tityal has promised us that he'll stay.
No, I'm there. I'm there. I'm there. Don't worry.
And till the end of the meeting.
Yeah,
So that's
I'll be
honor.
happy to have a discussion, after each presentation. No
Thank
issue.
you, sir. So it's my pleasure and honor to introduce my friend Dr. Gaurav Mishra. Gaurav is the director and senior consultant at Drishti Eye Foundation in Meerut. He is he has been doing a lot of topical phaco surgeries since many years. And what I've known Gaurav is more for the way he explores the world. He goes on long chuttis. I do not know how he manages. He does a lot of travel. So Gaurav has numerous international presentations at the ACRS. He is known for presenting what is called as a single-handed phaco surgery. I don't understand much of that because I've been tuned to bimanual surgery, but yes, Gaurav, I think the cataract surgeons would do. So you have pioneered the single-handed phaco surgery, the reverse chop technique. These are some of the numerous, some of the things and the numerous contributions we've had in ophthalmology. I welcome you, Gaurav, to speak to us on Panoptics. You can share your screen and we can have questions. Thank you.
Thank you, Ajay. And thank you, Noida Ophthalmic Society, for inviting me. I'll just share my screen. And a video show by Dr. Titial. You have an intermission. So in the intermission, what you have is you get slides to see. So I'll be putting my slides on. Just a moment.
So we have people who have joined in by YouTube and Facebook, and there's a different platform on which.
Just a moment. I'll take one moment.
I'm,
Okay.
I'm just.
Okay. Yes. You can continue, Ajay. Just a moment.
Dr. Neetu and Professor Goel, so if you have any questions for Dr. Titial.
Dr. Titial,
Namaste,
I
sir.
just wanted to know. Hello.
Namaskar, I've seen you
Hello,
after a long
guest.
time.
How are you?
I'm fine, sir.
So once the rexis goes to the mid periphery and it is tending to go away, so how will you manage with what type of viscoelastic you will like to inject and where, in the center or in the periphery, and how to control it?
Very nice question, sir. You're right. If Rex is trying to go to periphery, that means the pressure from inside is more than the pressure from outside. That's why the Rex is going to periphery. And you know that the curvature of lens is such, tear will extend to periphery here. So we have to make a pressure equal either side. So if your Rex is going to periphery, always make sure you inject, dispersive viscoelastic from the distal part. Come towards a tear. Don't inject for central area because that will further increase the tear. So go beyond the tear area, inject there, put a bolus so that you prevent the tear going to posterior side. And then subsequently you can nudge the capsular axis margin towards your side so that you have, the tear doesn't go to a periphery. So if you have a absolutely clean tear, then chances of tear going to periphery much more. If you have a little bit of flap which is there, that holding flap and tearing is easier. In such cases, sometimes if you feel that tear is going to too posteriorly, you should initiate another tear from other side or just adjoining to that and rotate that flap to make joining that area, which I showed in one of my initial videos. In that way, you can manage that absolutely acute angle tear which is there in these cases.
Okay, thank you.
So now can everybody see my screen?
Yeah, we can see.
Okay, so I'll proceed with the things that trifocals vision uninterrupted. And by the time we are talking about this, Bess Joseph has already the edge of space. So he's created history now. And after such a wonderful talk by Dr. Titial and seeing his wonderful videos, everybody needs a break. And that was the intermission. And now this will be the slideshow in the intermission. So please be with me and bear the things, because after such a good speaker, you will have to bear with me. So I belong to a city which is known as City of Meerut, from where the struggle started in 1857. But the things that we have to think is that now Meerut is very well connected to Delhi. It is now a 40 minutes drive. And now we are going to soon have the regional railroad transport. So Meerut is always on the forefronts as in terms of the cities. So like Bess Joseph's, yesterday's solutions cannot solve today's problems. So first of all, let us come to the concept. What is the trifocal and when it was discovered and what are the things? So initially when it was discovered, it was based on the refractive principle, where an optic with smooth and continuous surface that bends the light rays, focusing them into a single point. This. Then came the diffractive IOLs. So the diffraction is an optical surface that contains physical steps that divides the light waves into wavelets that form the near and distant images on the retina. So this multifocal designs initially was refractive. Now they have the diffractive designs. This diffraction is basically bending of waves and around an obstacle or through a hole. These plane waves turn into spherical waves, and these spherical propagation form different diffractive points, which is known as the Fresnel principle. And this interference is the combination of two or more wavefronts. So this wave interference patterns depends on the phase shifts between the different wavefronts. This can be destructive as well as constructive. So this is the diffractive technology, and interference patterns are utilized in IOLs to create more than one focal points. So this is what that the step design which is present, this step design which is present on the posterior surface of the IOL, the width will determine the focal length and the height will determine. Counterpart to that, there the halos and glares increase, and there is a decreased contrast sensitivity. So this step width, which you can see here, this step width, which you can see here, this determines the additional power. That is, the shorter the steps, the higher is the addition. And the wider the steps, the smaller is the addition, whether it is 4, 3, or 2.5. Whereas these diffractive steps, if the height determines the energy representation and near vision. So if there are higher steps, there is more energy for near vision. Now, what I am going to talk about is Alcon trifocal, because I am mostly using these span optics. The advantage of these span optics is that the transmission has increased by 2% from 86 to 88%. And it distributes the light for distance, intermediate, and near. It has a non-apodized diffractive surface, and it sends energy to 3 focal points. This breakthrough diffractive approach allows a good range of vision for distant, and it is pupillary independent, because basically the striations are on the posterior surface, and they are from surface to surface. That is from the tip to the center. So the traditional trifocals have this design. The quadrifocal technology there are now 3 steps coming. But this enlightened technology, what they have done is they have made this distance vision, they have shifted onto this. So they have called it an enlightened technology. So what is the patient selection? This was about the technical aspect, which the physicists and the optical bench people are discussing about. Now, what is about the criteria of the patient selection? As you all know, that is bilateral implantation. As early as possible, the better the patient is. The operative astigmatism should be less than 0.75 in my hands. I do not know about other people, but what I think, it should be less than 0.75. Post-operative emetropia should be planned. Patient motivation should be there. High diopter glasses, hyperopia, spectacle independence. That is very important. That chair time given to the patient is very important. Hobbies like painting, playing piano, playing cards are good candidates. What I think one more important thing is farmers, housewives, and because the scenario has totally changed from watching movies to watching movies on the laptop, always using a mobile phone. So intermediate distance has become of more importance rather than anything else. Occupational night drivers, for all these patients, even a short-term glare or halo effect will be intolerable. This is a very important point. Counseling the patients and explaining them about the potential side effects and also the fact that they are easily tolerable with binocular submission and lesson with time is very crucial. So the preoperative assessment would be an accurate biometry, optical biometry are preferred nowadays. Most of us already have it. IOL formula, the Barrett-2 is probably the best one. Macular OCT is a must. Corneal topography is a must. Posterior corneal astigmatism, and all these should be documented. This is very important that most of the people are not doing macular OCT and corneal topography before going in for a trifocal IOL and TF film quality. So talking about that, still what every patient wants, this is his expectation. But reality is something different. So he has to understand that this is not the expectation. He has to live in the real world. Patients range. There are highly affordable patients who can easily afford these trifocal IOLs. There are normal patients also who can afford them, provided they are counseled well. Some of the poor patients are also there who want trifocals. In those, I suggest that we can always try Indian trifocals because they are coming up very good. Quality. This is a concern in ophthalmology. Why patients want to spend less in ophthalmology and more in cardiac or ophthalmic surgery? He can always extend his budget in ophthalmic or cardiac surgery. But why patients expect a low-cost surgery in ophthalmology? Why? Because we are the ones who have made a habit. So always use quality products. Ask them to enhance their budget. This is what a routine surgery would be. This is a normal zindagi with a surgery cost plus cost of the eye plus cost of the spectacles. Every 1 or 2 years change these spectacles. So instead of that, go for a Mentos zindagi with a trifocal IOL. Disadvantages of glasses, that what we are seeing nowadays is basically fogging, wearing the glasses over our mask, we get fogging and blurring of vision. So to avoid those common problems, it is better to go in for these trifocals. What a myth is that monofocals, mostly the patients are satisfied. In trifocals, patients are not satisfied. Is that so? No, I do not agree. I would say if you plan to give a 90%, 95% freedom from glasses to a patient, the patient is happy, the surgeon is satisfied, and our goal is achieved. In my small experience of 200 trifocals in last 1.5 years, I find that the uncertified and neutral patients are equal in both monofocals and trifocals. And these evolving technologies should be adaptive. The thing is, we think of space, we try, we fail, we again try, and space travel is possible. This is the key to success. 17 years later, Richard Branson has flown and now Jeff Bezos is there. Cost, please do not worry about the cost. You have to stretch it somehow. Why are we lacking in these things? We are lacking because we have the fear. Fear of what? We may fail. Fear of money. The only mantra that I would say is more implantation would lead to more satisfied patients. Acceptability is a challenge, definitely. But if institutions like AIMS start using trifocals or multifocals more oftenly, probably there will be increase in implants, there will be increase in the comfort level, and there will be increased acceptability. It is just a mindset that we are not planting more of multifocals. Once we start doing those, probably we'll have the same problems as a normal monofocal patient with a 6/6 vision has. It is the same way that we started with ICC, we started, and now we are on to Phaco with 1.8 or 2.2 millimeter incision. You can take my example. I was a myope with a -6.5 and a -7.5 in my eyes, and I had been suffering for last 50 years. Everybody said, no, LASIK surgery is not for you. But I, after understanding all those things, I plan to go ahead with LASIK with undercorrection in one eye. And I only know how satisfied I am. I would say that yes, if there is a new technology, you should adopt it. So my suggestion is get a 20/20 vision, get a good near vision, get a good intermediate vision. Take home message, when we are using foldable IOLs, we are using preloaded IOLs, we are using toric IOLs, multifocals, then why not trifocals in such large quantities? So thank you for a patient hearing, and I'll pass on to Dr. Ajay Arora. Thank you, Ajay, and thank you, Noida Ophthalmic Society, for inviting me.
Thanks, Gaurav. I think Dr. Goel and Professor Goel and Dr. Atul Singh have the discussion, and then we can have a video from Malcolm.
Gaurav, is it a lathe cut or it's a cast molded IOL?
So this I do not know this. I know that these are striations and they have a focusing power, whether it is lathe cut or this I don't know, sir.
Dr. Gaurav, sorry.
These lenses has to be
Dr. Chetial?
Cannot be lathe cut. They have to be, cast molded.
Most likely it will be a cast molded IOL.
Yes, sir.
Panoptic.
Thank you very much, Dr. Gaurav, for this excellent presentation. But I would like to ask you a few questions for the audience. One is that always bothers me, that whenever you create multiple focus, you always compromise with the quality of the vision, because you're splitting the light. And this new technology which has come, which is the X-ray technology used in the VBT, what will you prefer, a panoptics or a VBT?
See, Atul, very good question. Since I am using only panoptics, I haven't tried this Vivinity. But yes, I have heard about this AMO Abbott lens, in which there is a chrome design, which have an ADOF technology plus this technology, which increases your depth of focus as well as distance of focus. So the gaps in between the distance, intermediate and near would be taken care of. But I haven't used the other lenses. I am sticking to the panoptics because I am getting good results. And yes, there are some compromises, but if we are settled with the compromises, if a patient is settled that he is able to see distance, intermediate, near with a reasonable good vision and quality of vision, I think it is a must that he should go for it. Until unless obviously he's a A+ personality.
Right. Because
I would like to have Dr. Kitial's opinion also on this.
Yeah, I would like to have his opinion regarding comparison of these two lenses.
Rightly said by Gaurav, these two lenses are totally different lenses. And if you look into BBT lens or enhanced lens from AMO, they are basically going to give us some sort of a near vision for these patients with a little bit of increase, you can say, depth of focus happening in these cases. But they are not going to give you a range of vision which is required for our patients. In that, trifocals are today would be a better lenses where patient will be much happier because they'll have a good intermediate and near vision also. The advantage of Alcon lenses, panoptics, is these lenses have a highest light transmission amongst all the multifocals which are available in today. And around 88% lenses, light is transmitted. And the beauty there is the fourth focus which Gaurav talked about, gives you enhancement for intermediate and distance also in terms of increasing their contrast. And patients have a best intermediate vision as compared to other lenses, which people use like a Symphony, which has an extended depth of focus, where the near vision was a major compromise for those lenses, which is now better with these trifocal lenses. So we pick up today's generation trifocals. They give you a best intermediate and near vision both. I think Alcon has an advantage which gives you a better intermediate vision than any other trifocal lenses in today's generation.
Can I say something, Dr. Atul?
Yeah.
you know, you must have read in papers about this Pegasus thing, which has come up.
Yeah.
You know, so I looked up what is Pegasus. It's a flying horse where the warrior wants to reach the Mount Olympus. And I think this is for all of us in cataract surgery, it's a Pegasus moment. All of us want to reach that Mount Olympus so that we can give our patients a heavenly vision. But that heavenly vision has not yet reached. And, you know, all of us fly on these horses, and like that warrior of Pegasus fell off, we are not yet reaching that. I think Dr. Ritu is possibly going to add to that Pegasus moment in her talk.
I'd just like to come up on one thing, as Dr. Gaurav said, that bilateral implantation is a must. But I must share with you that in young patients who are presbyopic and who kind of don't want to, hyperopic patients, of course, who do not wish to, you know, they cannot go for LASIK, they do not want to wear glasses. I have done unilateral implantations, and such patients have been, to my surprise, very accepting of, the panoptics. Because with time, with COVID and all, yes, near vision and intermediate vision is the most important.
Yeah, I totally agree to it, Dr. Ritu. I totally agree. But there are only some patients who might be very selective patients. But if you pre-counsel them that, yes, sooner or later, the other eye should also be operated, I think that would be the best option if you want to get away with the things. But yes, of course, if unilateral implantation is a patient is very satisfied, then it is a different issue.
Dr. Saurav, you have been doing a lot of panoptics. What is your impression and what is your take-home message on this?
Yes, I've been doing quite a few of panoptics, and I have actually done a mix and match as well. I have put in a symphony in one eye, that is the extended depth of focus vis-a-vis the panoptics, thinking that the symphony would have less of the halo effect, and the patient gets the best of both worlds. And I do see, when I ask the patients to compare head-on, in the same patient, the symphony, in the other eye, a panoptics. Now, one sort of the
we have lost you,
your
sir.
connection. We have lost you, Saurabh.
Symphony there, but in terms of the field here, such matches, I think, the way forward, and that's what I am doing. I'm planning to do in most of my patients.
Can you just repeat?
Saurabh, your connection was a little this thing. If you can repeat that.
I know the connection one. You'll have to excuse me in case. Right. So I was saying that yes, we at our hospital have been putting the extended depth of focus lens in one eye and the trifocal in the other eye, and the patients are pretty happy. When you ask them to compare one eye to the other, the slight glare with the panoptics is more, but it with use of both the eyes, the patients are pretty happy.
Okay.
So I have a question for Dr. Gaurav.
Yeah, Dr. Neetu, please shoot.
Please carry on.
I think I mute. Yeah, I have a question for Dr. Gaurav. So if you have a myopic patient, Dr. Gaurav, when you're planning a panoptics or a lens like that in that patient, would you be keeping the patient myopic or slightly myopic still?
Gaurav, are you there? I don't see Gaurav.
Let me answer this question, Ajay.
Yes, sir.
Whenever you are going for a multifocal or a trifocal lenses, the correction has to be absolutely emmetropic. Especially these trifocals now we have, has to be emmetropic. Otherwise, you're going to lose both distance and intermediate near. So we are going to compromise all three focuses in these cases. Unlike extended range of vision, there you can go a little bit of myopic sometimes. That is what I did in my all symphony cases. I have to go first myopic in these cases, which will range from a 0.1 to 0.3 myopia in these cases. But now, if I go a trifocal lens of like panoptics, I have to go emmetropic. Even I have a 0.5 cylinder in keratometry, I go for a T2 toric also, because even 0.5 can distort the vision in these cases. So if you are using a trifocal, you have to correct the astigmatism as far as possible. So even 0.5, 0.6 is a, you can't leave that toricity in these cases. So that's the one important point in these cases. But now you have another lens which is also being, coming from AMO, that is called synergy lens. There I go with either 0 or slightly towards the positive side. So that's a little different because they have a different concept design in these cases. But panoptics, which I have used, I always go for an emmetropic power or around 0.1 towards a myopia side. I never take 0.3 or more in these cases.
What is the effect of pupillary size and angle kappa on the panoptics?
Yeah, but Atul, very good question. There are two important aspects when you're doing investigations, examination for these patients. Apart from the looking into astigmatism and a good biometry in these cases, you rightly pointed out angle alpha is a very important consideration for IOLs, especially bifocal, multifocal, and trifocals. Even for lenses which are based on you can say with little bit of orientation design, which is to cover the angle alpha in these cases. And if you have angle alpha more than 500 microns, has to be, will be a difficult case in a post-op period as such. Though we have implanted trifocal in those cases also, but larger angle alpha is going to be a little difficult. The trick which I do normally, sometimes does help you also. When you implant the lens, make sure the central ring of these trifocal lenses coincide with your the coaxial light, or push the lens little towards the nasal side, so that you know that visual axis will be slightly nasal to the your optical axis. So that is the trick which you need to do in these cases. But if you have aberration measurement for these cases available, like eye trace, which gives internal aberrations, make sure your cornea is absolutely normal in these cases. If your cornea has more aberration, especially HOA, which is more than more than 2 or so microns, then the case may have little difficulty. So these are two areas. The cornea should be good, and the angle alpha should not be more than 500 microns in these cases.
So I think this discussion is so interesting, but we need to play the video of our sponsors. If you don't mind, I have this job.
You have to run that.
I have to do this. So I'll quickly start on the video. We'll have the subsequent talks, and then we can continue with this. I'm sorry for this interruption. I hope this is seen.
Introducing the Acrosoft IQ Panoptics IOL, Alcon's next advancement in presbyopia correcting lens technology. Unlike some multifocal lenses that require apodization to manage light, the Acrosoft IQ Panoptics IOL features a non-apodized aspheric optic. This unique diffractive structure consists of 15 individual steps that allocate light energy into 4 focal points. To optimize performance for a full range of vision, the third focal point is redistributed, amplifying the distance focal point. This design allows the Acrosoft IQ Panoptics IOL to transmit 88% of light to the retina for exceptionally high light utilization in a presbyopia correcting IOL. The diffractive optical structure of the Acrosoft IQ Panoptics IOL has also been designed to provide excellent quality of vision to a wide range of patients. Featuring a 4.5 millimeter diffractive zone, it's less dependent on pupil size than other multifocal designs. And unlike other trifocals with an 80 centimeter intermediate focal length, the Acrosoft IQ Panoptics IOL provides a working distance of 60 centimeters. This is a more comfortable distance for many common activities, such as computer work. The Acrosoft IQ Panoptics IOL is designed to deliver a natural range of functional vision. providing patients with quality sight for their daily activities. The first hydrophobic trifocal lens built on the clinically proven Acrosoft IQ platform. The Acrosoft IQ Panoptix IOL delivers advanced presbyopia correction for your patients.
Thank you all very much. I will give the mic back to Dr. Atish and Professor Goel, and we can have one more video from Alcon at the end of the meeting.
So, Dr. Tityal or Dr. Gaurav, is there any difference in the number of the circles in panoptics and multifocal IOL?
Yeah, there are a lot of difference between the panoptic and the multifocal. In Restore, there were larger number of rings and apodized surfaces. That means the distance between the rings was decreasing as you go to the periphery. Whereas in this, the distance between the rings remain the same. The number of rings has been decreased and the central bullseye size has been increased.
No, because
So that,
multifocal IOLs, they have approximately 20 rings.
yeah.
And
that,
in panoptic, how many rings are there? Approximately?
there are, it has already been told there are 19 rings.
18.
There are lesser rings than those in the multifocals, and the diffractive zone has 4.5 millimeter, which was extending to the periphery. Initially in the multifocals, periphery tak extend kar raha tha, but in this, the number of rings has been decreased, and the central bull zone, jo kehte hain, that has been, the size has been increased so that it can have a better tolerance of decentration. So, agar slight decentration bhi hoga, it is better tolerated as compared to the multifocal in which the central zone was very less. So, jara sa bhi usme decentration hota hai, it was not well tolerated.
Okay, okay.
So, Dr. Gaurav, in your practice, is panoptics or a similar lens offered to most patients? In the sense, of course, the ones with a macular disease or a straight-on contraindication you would not be offering. But is it because the reason I ask is that some of us surgeons hesitate for reasons that it's an expensive lens. And I like the way you said that the more lenses we put in, the more satisfied number of patients we're going to have. So are you offering these lenses to a wide array of patients in your clinic?
Yeah, definitely. One of the indications that I told you was farmers, because most of the farmers are coming in the Western UP as far from a very rich belt. Yeah. They have the money, but nobody is offering them trifocals. Why not? They say that they do go to the jungle, they cut the khet mein jate hain, and it is very difficult for them to use the glasses. So at least they have a workable vision for both distance, intermediate and near. They are using mobiles. So it is very handy for them to get these lenses implanted. And I have done a number of cases of farmers who are still working very well. So I definitely think that farmers is one criteria where I would say that this lens should be implanted, a person who can afford it. And yes, one more thing I would like to share is I was with Dr. Gunderson at a Ghaziabad ophthalmic conference, where he totally said that I would not implant trifocals in my diabetic patients. But what I see in my practice is every third or fourth patient is a diabetic patient. Some of them are very well controlled. This macula is very healthy. They are on medication, very religiously following the protocol. I would definitely personally feel that yes, I should have implanted a trifocal if everything is normal. At least we can give a good vision to them. So I think that diabetic patients, especially in India, when every third patient is a diabetic, I think it is whether Dr. Tityal agrees to me or not. And one thing more, I would ask Dr. Tityal to please push these trifocals in AIMS so that at least we also get some pieces in the periphery.
Well, I'm glad you spoke about the panoptics lens in diabetics, because recently I was having this conversation with Dr. Ajay, Dr. Ritu and other people on the group, since I had to operate on a physician who's a myope to the order of -8 and a diabetic. but he did not really give me a choice because he says it's either panoptics or nothing else. So I recently,
that is what, yeah, that is what I am telling you.
yeah, because I had a few apprehensions.
Yes, I operated the director of SG groups, that is Sense Parallel Green and the bats we see, Mr. Puneet Anand. And I gave him both the options. I say your contrast will go down. That is for sure. But it is up to you. You want a trifocal, I will implant a trifocal. You want a monofocal, I'll go. He straight away said, no, I'll go for a trifocal. And he's very satisfied.
So can I
never know.
intervene here? I think, thanks, Gaurav, for the insight.
Sorry.
We have about 40 minutes. We have 2 more talks to go. And
Yes,
in case Dr. Vicky Tiwari joins in, we have to give him time. So maybe we can take this conversation forward after the talks.
Yes,
Sure. Yeah,
sure.
Dr.
Sorry
Atul,
for your time.
No, perfectly fine. I think we should. I had some opinion about this, but I'll tell you later. Dr. Atul, please.
Atul is not there.
Dr. Atul, you are muted. Dr. Atul, please unmute yourself. Can't hear you. Yeah.
Can you hear me now?
Yeah.
Thank you very much, Dr. Gaurav. Such an illuminating talk. We learned so much from it, and we will definitely give more push to panoptics after hearing your lecture. And now we invite Dr. Saurabh Chaudhary for his lecture back to basics of Phaco. Is a high volume Phaco surgeon, Phaco and refractive surgeons, and I'll request him to present his presentation.
Yeah, so thank you, Dr. Atul. And I will be talking about the basics of Phaco emulsification. And when we discussed about it, we were thinking that, yes, there are a few steps in spite of us all doing Phaco emulsifications. We tend to lose the sight on our basics. And if we keep that into mind, the basics of anything, the ultimate results would be the best. So what is Phaco emulsification? Phacos means a lens. Emulsification is to break up or liquefy by the use of ultrasound power. The nucleus fractus is to break it into smaller pieces, and that, I think, is the most important step in a Phaco emulsification procedure. But Phaco emulsification is here to stay. Most of us are doing it, and I think that if we don't keep up with the times, we will be left far behind. It has a lot of major advantages over the traditional ECC and SICS, and we need to just understand that, yes, it's slightly different, and we need to keep that into our mind. Now, as compared to the traditional surgeries, you need to think all the time. That means analyze each step. There are no fast movements. You just have to realize that there are no fast movements. You need to maintain the plane of the eye. That is, that you have to make sure that you are not moving the eye around. In fact, your hand should be going into a stable eye. The whole procedure can be broken down into steps and further sub-steps. So you should be able to take one step and then move on to the next step. Plus, you should know your machine very well. Now, I will just try to put down some basic points. Like, this is the first step which you usually do, the side ports. What you need to do is stabilize the eye about 180 degrees away. You can actually hold it somewhere else as well. But what you need to understand that if you're holding it elsewhere, you will land up with a mild intorsion or extorsion of the eye, and that will lead to a side port which might be leaky in the end. And if it is a leaky side port with your chopper going in, you might have shallowing of the AC and the PC coming up. So it is very important that we go back to the basics, understand how we should be doing it. I do not hold my globe with any instrument now. So this is one of my older videos. Similarly, the main wound, when you're making it, so when you're making the main wound, you actually stabilize the eye from the other end and just go in straight and come out, making sure that there is hardly any leakage. So I've gone in, come out, and actually you cannot see the main wound as well if it is a very smooth incision like this. So you hold it 180 degrees away. Sometimes we used to hold it somewhere else. They're going to be intorsion and the wounds are not. Coming down to the next step, which is the capsulorhexis, you you get back to the basics, you have to make the eye pretty, so the intracameral pressure should be more than the intralenticular pressure, so that you are not working on a dome. You should be able to stabilize the eye with one hand, get in with your whatever preferred technique it is, but I use a needle, so I go straight, then lift up a flap, and the next step is flatten this flap, and then I work on the posterior surface and keep it flat at all times. So the key is that this should be flat at all times, and the eye should, so in case you notice, my left hand is actually not pushing the globe down, or it is there to stabilize the eye. Always finish your capsulorhexis from outside inwards. Once the capsulorhexis is complete and you've made your main wound, you then go ahead with the hydro procedures. And in the hydro procedures, you get back into the mode that you go under the capsule, push a fluid wave, and as you see the fluid wave go through, you push it down so that it completes. Make sure it rotates. Now, I miss out on these steps right now, but as I said, that these are the basics. And if it is a hard cataract, I do make sure that my nucleus is rotated. I go ahead with my Phaco emulsification technique. Now, what I usually do is a direct chop, but what we propagate here, and these are some of the videos from our training manual, what we propagate is a stop and chop. The first bit of the stop and chop is, why the name stop and chop is because you start off like a divide and conquer. That means make a central trench, then stop there and start chopping. So what is trenching basically, and what are you doing with your Phaco probe is eating away the central part of the nucleus. What you do need to do is make a marker trench, you deepen the trench, you widen it and deepen it further. What is a marker trench is basically demarcating the extent of the rhexis margins. So you're actually making your first trench so that you know where your rhexis margins are. Thereafter, you are going deeper and you're not concentrating where the rhexis is, and you know that you don't have to exceed those margins. Then you deepen it until a level when the sleeve starts to push down the nucleus. Once you reach that, you need to widen it to 1.5 times of the tip, and then deepen it further till you get a red reflex, or 2.5 times the length of the exposed tip. So that's a video about the sculpting. I'll move on to the next one. This wasn't working, but let's. Right. So we made the rhexis. I'm going in, always go in with the irrigation on so that the AC is formed at all times. Getting in, the left hand is stabilizing the eye only. That's my first marker trench, and I know that I have to stay between these two first trenches. I'm deepening it. After deepening it, I'm just going to broaden it slightly. So that's what I'm broadening it as. Go in deeper. Now that the sleeve has space to go in deeper, I'm going deeper, deeper. And as I go deeper, I'm seeing a red reflex here. I've seen the red reflex, and I'm just going to make it slightly more deeper. And once the red reflex is there, I go ahead. This is a modified stop and chop. I'm going to split it. Because I made this trench, it is very easy to split. As you can see, this is a grade 3.5 nucleus. It's slightly hard nucleus, and you have to go to the depth to be able to crack it. Otherwise, it will not crack because it's a flexible thing. Now, each time you hold it, you have to go into the depth and hold and crack it into, and you have to do a multi-level cracking because it's a harder cataract. So you know that I'm doing multiple cracks and at a multiple level. So this is my chop which comes in, and this is the split. And each time my chopper is going slightly deeper to split it. I rotate it again, hold it, a chop, and the split which is going deeper with each progressive. I move on to the next mode here, and usually I chop all my pieces together, but this time I am removing the pieces once one heminucleus has been split up into smaller pieces. Nowadays, I make a lot more smaller pieces, especially in my hard cataracts. So you need to rotate the nucleus to the front of the tip and then do it, and not work in the subincisional area to get the nucleus out, because then there will be leakage and it can lead to shallowing of the anterior chamber, and hence the PC can come up, which can cause a PC rent. So that's one heminucleus out. Once that is out, I am going to move this around, and I'm using the Phaco tip because that's the blunter instrument out of the lot. Again, hold it, and I go back into my chopping mode and chopping it at a multi-level into smaller pieces. So that's half of the heminucleus. I'm going to break it into 4 quadrants. That's the So I usually chop all of them together, but here it hasn't been chopped together. And as you can see, there is a lot more movement of the whole piece because it hasn't been chopped first. I'm now going to remove it one by one. And as it comes out, my parameters of the machine might go down slowly because it's a harder cataract. And I will make sure that my PC is not getting shallow. And everything is now slower. And when it's the last piece, I have to be very careful that I am not going to have any surge. And I do not want the tip to be occluded for a very long time, because if the occlusion breaks, there's going to be a surge. So I am going to be slightly, I'm not letting the occlusion to happen. And with the help of the same tip, I'm removing the last piece, and I am slow now. And I'll skip this. So once I'm trenching, I get into Phaco position 3 and move forward at the same time. I reach the end of the capsule rhexis. So as it is shown here, the Phaco starts here. The Phaco power increases its maximum where the nucleus is the hardest. And by the time it reaches here, the Phaco power is almost 0. So I move into the foot position and move forward at the same time. I reach the end of the CCC. I stop there, and I'm already in foot position 1 and retract back in Phaco position 1. That is irrigation. As I did show in that video, that I need to split it, and if I haven't gone deep enough, this will be a flexible plate and it will not split into 2. I have to be in the depth for me to be able to split it into 2. So I am keeping it in the depth. This is a video of the splitting of the nucleus, but I think while chopping, you need to hold it. So unlike well trenching, when you are eating away the capsule, here you have to hold it. Hence, your power becomes less. There, so as vis-a-vis where when you were trenching, you were using higher power. Here, the power becomes less, but the vacuum and the aspiration flow increases. To hold it, your Phaco tooth should be able to occlude the tip. So that's why I said you have to be deep enough, and the chop should go along the fibers. You should not be cutting the nucleus. So you have to mentally think where the fibers are so that you're able to chop it well. So while chopping, you hold the nucleus, you retract it back slightly, you chop and then split it. So that's the video of a chop. It's not working. I'll just do it. So use a sharp tip of the chopper, hit it down in front and left of the Phaco tip where you've held it. You'll see a crack. Pull along the crack and use the flat of the chopper to split it. So it's almost like an inverted L what you're making into the depth, pull it along where the tip was occluded, and then chop it. So that's the safe zone what I was talking about. Do not try to hold your nuclei here. Always move it into this zone, and we call it the inverted keyhole through which you should be working. Then you come on to the cortical removal. Just be careful while you're doing the cortical removal. You hold the cortex, increase the vacuum, and then you pull it into the center. And once you've held it and you're pulling it to the center, make sure that it comes to the center. And now you can actually, with the aspiration port up, put the foot pedal down. You can push the foot pedal all the way down because it becomes safe. The PC will not come up, especially with this bent tip. So holding the cortex, pulling it into the center, and pulling it to the center, and then eating it away in the center. So this bent tip helps you take the subincisional cortex out as well. Next is the IOL implantation. It's no big deal. You just have to load them. Each company will come and tell you how to go about it. That's the IQ lens which is going in place. You have to inject it in, and then you have to dial it in, or you can push it in one go, what we do usually now. Viscoelastic removal, you need to first remove the viscoelastic over the IOL. I go to the angles and towards the cornea to remove it. And then definitely in all my cases, I am going behind the IOL to remove the viscoelastic. And this is a very important step, and you have to learn it in all your cases, because in your toric cases, it is a very essential step, because if you do not remove it in the post-operative period, the toric lens can also move from its position. Thank you. I think that's what the little tips I had to share. So these were the basics where I wanted to take you. Thank you.
Thank you very much, Dr. Saurav. It was a beautiful presentation, and we were taken back to our basics, and we are learning so many things. Any questions from the panelists?
I
Dr.
would like to ask, oh, sorry.
Carry on.
I just wanted to ask Dr. Saurabh, because they're doing Phaco training there. So do you advise the beginners to use a cystitome or forceps?
We advise all our, so we're basically using the cystitome, and that's how we train them. But all trainees coming in have to use forceps as well in regular cases, because once, so what we have seen is that once you land up with the white cataracts and you need to use the forceps, you're already under a stress, because in those cases, it's a milky white cataract. It's not a regular capsule rex is what you're doing. So if you use a capsule rex's forces in your regular cases, you'll be a lot more comfortable doing it in those cases as well.
Yeah.
So we are training with both.
I think
Dr.
that's very
Saurabh, I have a
important.
question. Oh, sorry.
No, go ahead.
Saurabh, can I ask you a question?
Yeah, sure, Gaurav.
Why? Yeah, I don't understand, why don't you start training your trainees with direct chop method instead of a stop and chop method? Because I find it is difficult to learn, but once you learn it, it is much easier to go through.
Okay, Gaurav. I think traditionally it evolved with the divide and conquer techniques, went onto the chopping techniques, and then came the stop and chop. So that's how the name evolved. That means I'm starting off like a divide and conquer and then doing the chopping techniques. So in the history of the nucleus practice techniques, the first were the divide and conquer, the four quadrant chopping, four quadrant cracking. Then came the chopping techniques. Now, when we also learned by doing the stop and chop first. Somehow we felt that, yes, as I evolved into a direct chop surgeon, the complication rates were slightly higher. And we have seen that some of the trainees, if they have these too many complications in their first few cases, they no longer are interested. There's a fear factor which comes in. So we feel that, as you rightly said, that yes, it is slightly more difficult. And what I have seen is that stop and chop is a great combination of the direct chop as well as the, so if somebody learns stop and chop, they can easily evolve into a direct chop surgeon, or if there is a very hard cataract, do a four quadrant cracking, right? So that's why we say that it's a good combination of the two. That way they're learning how to make a trench. They're also learning how to chop. And it is very easy for them to evolve into direct chop surgeons if they've learned the stop and chop. That's what our experience is. And as I said, that each surgeon is different, but that's what we have seen.
Okay, sir, I have a question for you. I saw in your video that you're more used to doing aspiration irrigation with the coaxial one.
Yes.
You don't use the bimanual one.
Yes.
Any specific reason, or it just cuts down your time period?
It cuts down my time period. I used to use the bimanual, and sometimes when I do a hydro insertion of the lens, I do use a bimanual. But somehow, when we started learning, bimanuals were not there. They were not in vogue. You had to purchase a separate bimanual. The machines came with a coaxial. So maybe we learned it that way. So there was a phase when even like most of the companies came with coaxials. Then there was a phase then bimanuals started coming in. The company started pushing for bimanuals, and it's back to the coaxial phase. So it is very it is which surgeons likes what. When we are doing a training, the trainees have to do the coaxial as well as bimanual techniques.
Have you used the silicon coaxial one?
I haven't. I've seen it, but I haven't used it. We don't have one. So actually, I have used it also, but that is in the sense that I've done it for a very few cases. There's some surgeons who come from abroad to help us out whenever we have got a large camp. So they come to basically help us out, and they get some of their instruments. So I've used it. But it is what you get used to. It's what over a period of time you get used to, and that's what you find more comfortable with. So I think it is not one is better over the other. It is just what you are used to and what is safer. It might
Absolutely right.
Technique might be safer for me, and something else might be safer for you. But it does not mean that I am wrong or you are wrong. It's our way of doing it, and both are right.
Dr. Goyal, you'd like to ask something?
I just wanted for that what bottle height you will keep once the capsule is ruptured in Phaco when you are removing the nucleus and two nuclei, one of two parts you have removed and two quadrants they are left. So bottle height normally what do you keep and what will you reduce the bottle height to?
Right. If I'm using the gravitational method, my bottle height does come down. All my parameters actually come down. It totally depends what sort of a rupture it is. So if there is already vitreous there, then my approach will be totally different in the sense that I will not start with my phaco emulsification. I will first do a vitrectomy, and definitely in vitrectomy, the bottle height comes down very low. But I will first finish off the vitrectomy and I'll try to dislodge these pieces and take it over into the anterior chamber and put it safe somewhere over the iris. I will try to do a good vitrectomy and then remove the cortex once the vitrectomy has been done with the help of the same probe, which is in the irrigation cutting mode, or I might switch over to a bimanual IA. All my parameters will be very, very, very low, because if my parameters go up, if my bottle height is more, there will be more infusion, more vitreous will come out. Let us suppose there is no vitreous loss, then I will use the same phaco probe with very low parameters and try to get it out and do a scaffold technique like what Dr. Tityal was saying, that I want to implant the IOL and then remove the last pieces then. So as I said, that it is a very difficult question to answer because it can be at any stage, and each stage would have a different management technique.
No, if there is no vitreous, so normally you might be keeping at 80 to 85 millimeter, no? 80 to 85 centimeter.
100 to 110, sir.
100 to 110. And if there is a capsule rupture without any vitreous loss, will you like to reduce it to what?
It will come down to almost 70, 75. It will come down to 70, 75. All the parameters will come down. The aspiration flow rate will come down. Everything will come down.
Okay. Thank you.
So it's almost called a slow motion phaco emulsification. All your parameters come down, all your movements get very slow. You need to manage each piece separately, making sure nothing is dropping at the back.
I think we should keep it at 50 to 50 centimeter rather, because it becomes very slow. Then only you may not extend the capsule tear. Otherwise, even I feel that even 80 centimeter also is quite a lot for this capsule tear.
That's what I said about
only
70.
Thing is that
about 70. So right now we've moved on totally onto the active fluidics, and it even comes down to 25 there. Usually we keep it as 40. It comes down to 20, 22, 25. So that's what we do.
Well, Dr. Saurav, when you're reaching the last piece, when you have almost finished your phaco and you're in a hurry to go and you're eating the last piece, what precautions you take? You change the parameters. What other precautions you take during that time?
So I think with the improvement in the machines, you tend to forget this important step. But I remember that in our older machines, there was another step to it. So we used to have Phaco 1, Phaco 2, Phaco 3, and Phaco 3 was meant when we were trying to remove the last piece, and without even telling our attendant, they used to come into the Phaco 3 mode. Everything used to slow down at that time, and besides that, all your movements used to slow down, and as I said there, that you make sure that you're not occluding the piece. You're actually using the chopper or the second instrument to stuff it in fast, so that if there's occlusion, there is a chance of a surge which is happening. So sometimes whenever I get to occlusion, I try to just give a small burst of phaco so that my occlusion is broken faster. There are times, let's say in a very hard cataract, which we've done and we've spent most of the times. I know that most of my rents happen in those cases, which are hard cataracts, and it is during the last piece removal because I am using a lot more power to remove this hard cataract, and hence the chance of a surge is a lot more. At this time, you should push in a viscoelastic if like in all probability in a hard cataract, we'll be using something like Dr. Tityal said, a viscoat, dispersive viscoelastic, and I'd like to push it in so that the PC stays back. So that's what we should be done. But as I said, that it is maybe with some experience, it is also with the better machines, with better fluidics coming in with the better machines, we tend to forget about it. But it is very, very important that we need to slow down and make sure that we do not, the last piece is the most important piece to come out.
What I usually do is to set the machine on the epinuclear setting. And
Yes.
as you said, use your chopper to stuff it, and it works very well. It keeps the capsule away. And it's a very slow process, so it takes it away very safely.
That's exactly what I meant. Earlier on in older machines, we used to have a Phaco 1, 2, Phaco 3. Now there are these settings which are already named as the scult and epinucleus and things like that. So you have to fix the parameters on the lower, get onto the epinucleus mode and remove that.
Thank you so much. I think now we should move to the next speaker. And
Dr. Atul, I'll have to take your leave. Dr. Atul, you have to excuse me. I need to go. I just have to rush somewhere. I'm sorry about that.
No problem.
Thank you.
Thank you so much. So, next presentation will be by Dr. Ritu Arora. She needs no introduction. She is a very high volume phaco and refractive surgeon. And she'll be speaking on the new technologies in IUL. So Dr. Arora, please present your paper.
Thank you, Dr. Atul. Yeah, I hope everyone can hear me. I'll share my screen. Yeah, good evening. So I'll be talking a little bit about the newer advances in intraocular lenses. Dr. Gaurav has already made my task a little easy by his presentation. But yes, there's a lot happening on the front of intraocular lenses. As we know, IOLs are actually, the most common prosthetic device which is implanted. And there are more than 28 million cataract surgeries which are done worldwide annually. And that's, a huge number. And as you can see, this is the first lens that was implanted, which was the Ridley lens in 1949. And since then, technology has rapidly evolved with huge leaps and bounds. Along with our technology for cataract surgery, the intraocular lens technology has, I think, evolved side by side. As Dr. Gaurav had shown in his one of his slides, that initially we were doing intracapsular surgery. So that time we had no capsular support. So the lenses were AC IOLs or iris fixated lenses that were being used. And as technology evolved to ECC, where we were sure of a capsular support, we had sulcus fixated lenses. But now with more people moving to SICS and to, Phaco, where we are quite sure of having a good rhexis and where we know we can have in the bag implantation, there's been quite a boom in IOL technology. And also now, with the increasing life expectancy, lifestyles changing, people are of older ages being much more active, using digital screens, the expectations enhancing. Our cataract surgery has now shifted more to a refractive surgery. And hence, I thought this talk would may be useful because, all of us are with so many lenses being available, it's quite confusing at times which lens to choose. So we must be aware of all the new things which are happening in intraocular lenses. So the ideal lens would be one which is, of course, biocompatible, optically clear, and which mainly mimics the natural young lens. It should also be able to correct aberrations which are pre-existing. It should have a UV blocker. It should be sterilizable and should have a low PCO rate. But in the future, we may also like to have a lens which, has, which can be exchangeable, or one which can have an adjustable power, or a lens which can be injected through a very, very small incision. Already we are sub 2, but maybe in the future we would be even going smaller and sub 1. So we all know we've used these lenses throughout our years of PMMA lenses, gone through silicon, hydrophobic, but materials are constantly evolving, and newer materials like hydrophilic with a hydrophobic coating or copolymers are now available. And many more materials are under research. So we should know a little bit about the physics, in the sense that we all know about refractive index. And we know that a lens which has a higher refractive index is a thinner lens. So those lenses then can go through smaller incisions. And initially the silicon lenses that we used to use with the holder folder technique, they had a lower refractive index and they were thick lenses. But now the silicon lenses have also evolved, though we are not using them so much, but there are newer technologies, newer silicon lenses, which are going through smaller incisions. So this is one thing, that when we are choosing a lens and we want to look at this aspect, that what is the refractive index of the lens, so that it helps us to choose the kind of size that we are going to do for a Phaco technique. The other thing we must understand is the Abbe number, and this reflects the dispersion of the lens. So those lenses which have a higher Abbe number, they cause less of chromatic aberrations, less of dispersion, whereas lenses which have a lower Abbe number, they tend to cause more of dispersion and more of chromatic aberrations. So that's another thing that we would like to look at when we are faced with a new lens. So when we are choosing whether to try new technology, we need to look into these things. The other thing is the modulation transfer function. Again, these terms are all physics and very boring, and make us we don't even want to understand them. But understanding that the MTF of a lens helps to give us what is the optical clarity, whether the lens is, the object is being reproduced, the image, how similar is it to the object, whether the contrast is preserved, the resolution is preserved. So a lens which has a good modular transfer function would be somewhat like this, which would have a good slope. And those which do not have a very good modular transfer function would have a steep slope. So as the spatial frequency increases, the complexity increases, the modular transfer function or the contrast reduces. So obviously we want to choose a lens which has a higher MTF. Then coming to the aberrations, we've been hearing so much about spherical aberrations, chromatic aberrations. So just to refresh the knowledge, we know what positive spherical aberrations are when the paraxial, the rays of light, they get focused at a point before. And you have negative spherical aberrations when the focus is beyond. So this leads to a blur and actually causes the halos and all which are associated with multifocal lenses. And again, we also have chromatic aberrations because the white light gets split and the longer wavelengths like the red, which travels and focuses further on rather than the blue. So you have achromatic lenses now, which take care of these chromatic aberrations. And again, they improve the image quality. So we've already known through Dr. Gaurav's talk what, monofocal lenses, you have a very sharp single focus. Whereas with multifocal lenses, you have two or more foci, depending on whether it's a trifocal or a multifocal or a bifocal. But now you also have extended depth of focus lenses where instead of having a single point or a 2-point focus, you have an extended area of focus. So that way, the depth of focus increases and these lenses are giving an elongated focus rather than a single focus. So coming to designs, we are still largely, most of us using, I would say 80 to 85% of our practice is on monofocal and toric lenses, and I will not be talking about these. But multifocal lenses, bifocal or trifocal lenses, the extended depth of focus lenses, and the newer lenses, which are the wavefront based lenses, these are going to occupy greater space in our, practice in times to come. And I totally agree that, we need to know about these lenses. We need to evaluate them, adopt them, and only then we'll know which ones really work best in our hands. We also have accommodative lenses with which we had a pretty, unhappy experience earlier, but newer lenses are coming. And I'll be talking a little bit about the future lenses also. So as I feel that presbyopia is now really the big barrier to cataract surgery. And if you're not going to correct presbyopia, I think patient satisfaction is really going to go down. And this mainly is a balance between three things: the image quality, the depth of field, and the dysphotopsia, because no one lens gives you the perfect, picture. So you have to balance these three things in all our lenses. But more than that, we have to understand firstly the patient's need, do a detailed examination, and only then can we help our patients to make the right choice. So earlier were the refractive bifocal lenses, which had different zones. These were pupil dependent. They were very sensitive to decentration and caused a lot of halos and glares. And they have largely gone out and are not being used much. Though there are many Indian lenses which are still based on this bifocal technology. So these lenses are not totally out. There are a lot of lenses available. So when you are evaluating a multifocal lens, one should know, is it a refractive bifocal lens? What are the pros and cons? And with good patients, acceptance, it's not that these lenses don't work well. As long as the patient knows, if the patient is a housewife, this lens could still work very well for her. So the other ones are the diffractive lenses. Again, these we have had a very large experience with these. We use the Restore to, with very happy patients. And here, as Dr. Gaurav had already spoken about, the light gets split into two. So obviously there is a, you have a, negative aspect that you have lower contrast. You do have glares and halos, but again, they are not as much. And these lenses can be pupil independent. So the apodization is, of great advantage in that you get better near correction in these lenses. And again, these lenses, because they have an outer refractive area, they give very good distance correction and very good near correction. These lenses are less pupil dependent, and in fact, they are what you call pupil optimized. But trifocals are the new kid on the block, and Dr. Gaurav Mishra has already told us about it. I would just like to specify that these trifocals are giving us a pretty much functional vision. And patients are highly satisfied because you are getting very good distance vision, extremely good near vision, and very good intermediate vision. Of course, the gaps are there, but most patients do not notice them. And again, the halos and glare with these trifocals is vastly reduced with newer designs. So you have the Zeiss lenses. I've had quite a bit of experience with the 80 Lisa also, and the Alcon Panoptics. And I must say that although, the 80 Lisa gives you less of near vision, patients don't really complain too much, especially when you've done a both eyes implantation. Patients are mostly very happy. And even if they have to wear, I've really not given near glasses to any of my multifocal patients. Mostly, if you tell them to use a little bit more light or to get the right sweet spot of their, reading distance, patients are extremely happy. So I'll come to the extended depth of focus lenses, which is a new concept. And the aim over here is to create a sharp image over a continuous range. So instead of monofocal lenses where you have a single focus, here you have an elongated focus. And thus the image which is for near and distance is moved apart. So that leads to less of overlapping and less of confusion and blur. Of course, the image quality is somewhat deteriorated at the expense of the depth of field. So the image quality may not be as good as a monofocal, but then you gain in the fact that you get good intermediate and a little bit of functional vision also. Now, the EDOF lenses are actually, I was also, when I was reading about them, there's quite a large variety of these lenses available. And recently, we've been pretty much bombarded with, various MRs coming and telling you to try out the new lenses. And at times you don't know which one to try and which one not, which technology to trust. Because, trust comes only after you've had a lot of experience. So I guess one has to, sort of dip and try different lenses, gain experience, and then realize which ones work for you. So the new lenses that have come, which are based on spherical aberrations. So they induce a little bit of spherical aberration and thus give you an enhanced depth of focus. And you also have lenses which are hybrid lenses, which are actually low add multifocal lenses, but which are having an EDOF element added to it. So there's quite a large variety of lenses available now. So the new ones, like the spherical aberration control lenses, they have a central area which has a positive spherical aberration surrounded by an annular ring of a negative spherical aberration. And because, as I spoke earlier, these rays of light get focused at different points, and that is how you get the extended depth of focus, which is quite continuous. And these lenses work very well for distance, as good as monofocal lenses, good for intermediate, but near vision may not be as good as what you get with trifocals. So the Technis Eyehance is also actually a modified monofocal lens in which you have a slight, positive spherical aberration in the center. And so it gives you a little bit of intermediate vision, but it will not give you near vision. And in such cases, I personally have not tried micro monovision. So these lenses are okay for people who don't have much of near activity, who majorly want, distance and intermediate vision. You also have these new small aperture IOLs, very interesting concept. We've always used pinhole in our refractions to see how well patients improve. And these are basically based on the same principle, just like the camera inlay. And they can be used, very useful in cases where you have, post PK or post keratoconus cases, where you have a very high, corneal asphericity and aberrated corneas. In such cases, when no other lenses can give you good vision, these lenses can come to your rescue. Now, the hybrid lenses are also a very interesting concept, where you have the EDOF married to a low focal multifocal. So these lenses, again, they are reducing your dysphotopsias, but it's not as though you are totally, patients totally do not have photic phenomenon. The photic phenomenon will be there, but it is much reduced. So in this, you have the Technis Symphony lens, and you also have the new Technis Synergy lens, which is actually a bifocal lens along with the EDOF. So it gives an elongated focus. So even if you have a little bit of spherical residual power, the EDOF aspect takes care of it. So if your biometry is slightly off, these lenses still work pretty well, unlike the trifocals where you really have to be spot on your biometry. Some new lenses which have been, I have personally not tried, but they are now available in the Indian market, is the Lucidus lens, which is by the Swiss Advanced Vision. And this is a hydrophilic lens, which is aberration neutral. Again, it is based on the aspheric zone. It has a central 1 millimeter aspheric zone, which gives you near and intermediate vision. And it is surrounded by a refractive zone, which gives you very good distance vision. The Appaswamy lens, the supraphobe in focus lens, is also based somewhat on this, concept. So we do have large variety of lenses, and I think there's no excuse for us not to give our patients, good intermediate or near vision. I think the concept of just going with monofocal lenses when we have so many options available, I think we should look into these newer lenses and see what suits best in our patient. Now, the new lens, the Vivity, which we are all, pretty excited and looking forward to its formal launch, is again a very unusual lens, which is based on the wavefront shaping. So basically, the wavefront in these lenses, they have a central platform, which is altering the wave of light. It is collapsing and stretching it, and so it is forming an elongated focus. So these lenses, again, they give you very good distance vision, very good intermediate vision, but the near vision is somewhat compromised and it's only functional. So again, I would say if your patient is not very much fixated on near vision or is not unhappy of using near vision glasses once in a while, these lenses could prove to be extremely useful because they have hardly any glares and halos. So I would say I'm pretty excited and looking forward to having an experience with the Alcon Vivity lens. The future is, full of new technology that's coming, newer types of accommodative lenses, adjustable IOLs, and modular lenses. So I'll just briefly touch about it, that the accommodative lenses initially, which we were using, the Crystal lens did not really stand the test of time. But true accommodative lenses are also, under, I think, being,
Dr. Vasant Verma.
And these lenses would really change the game. You have the light adapting lens also, which is FDA approved, and let's see when it gets launched in India. And the advantage of such a lens is that even if you have a refractive surprise, the lens power can be modulated and changed post-op. So there is a lot of excitement in the future with modular lenses are available where you would be able to change the optic of the lens. And you also have newer technologies like where you just put a ring into the capsular bag and you can keep adding, just like you have, sulcus fixated lenses, piggyback lenses. So there will be slots in which lenses can be added. So there's a lot happening in the future. And I think we have to keep, studying these lenses, experiencing them. And I personally feel that presbyopia correcting lenses are here to stay, and they are definitely going to dominate our practice. And the sooner we adopt them, the better it is. The key to success will always be patient counseling and a good patient selection. No one IOL is perfect. We have to weigh the pros and cons and decide which lens will suit our patient. And unless we, experience it firsthand, unless we counsel our patients and tell them, we will be missing out on technology, and they will definitely be looking with Google over here. They will be searching technology and going to the next surgeon who can provide it to them. So I think it's good for us to all start adopting the latest technology and giving our patients the benefit of that. Thank you.
Thank you very much, Dr. Ritu. It's such a beautiful presentation. I know it's very difficult to compile so many lenses. It's really, it's a big headache, because now the number of lenses are so many in the market, and compiling them in a lecture where the time constraint is there, but very beautifully presented. And any questions from the panelists?
I think it's already 9:10. I think.
Okay, there is a question from the audience who is on YouTube, Dr. Basant Verma. He has asked that how to prevent the snap entry through the main wound. So I would like to answer that question. See, first of all, the snap happens. Your knife has to be, the keratome has to be extremely sharp. Use a new keratome and make sure the tip is sharp. It is not blunt. Otherwise, we are going to apply too much force and suddenly it will give away. Second is keep the keratome absolutely horizontal and flat on the cornea. Don't tilt it on one side because it's going to cut through the cornea and the resistance is low. So it will again go into the anterior chamber very fast. And the third is while you're holding the globe, hold it gently. Don't force it towards you so that you're applying two pressures at the same time. And give it a rocking movement. Initially, just give the keratome a rocking movement side to side as you advance towards the anterior chamber. Any other tips the panelists would like to give?
I just wanted to ask one thing, is everyone, I mean, are all of us now completely doing temporal incisions, or are we at times tailoring it to the steeper meridian also?
Well, I for one is marking every case, whether it is astigmatic or not, and I'm always going on the steeper axis.
I personally go
Same with me.
always temporal, because now the induced astigmatism is so less.
Yeah.
And even if you go on the steeper axis, I don't think you, I mean, if it's a, very uncomfortable steep axis, you may cause more of astigmatism. So I would prefer to do a standard temporal in most cases.
Yeah, because then you stay
No,
away from the visual axis.
I think I always change my incision sites according to the steep axis. And I always, even if I am doing a limbal incision, if I think that patient is not going in for a toric and the astigmatism is more than one, even after doing incision on the temporal, the steeper axis, I put it slightly anterior, away from the limbus, so that the astigmatism is further reduced, if at all it is left over.
Because due to
Dr. Gaurav,
I
how
cyclotorch,
much
always
is
change.
your SIA, Dr. Gaurav? How much is your SIA?
Sorry?
How much is your SIA?
0.25.
So one doesn't really achieve much, that's what I meant to say.
So that is,
You don't really
see,
achieve
even
much.
if,
And
see,
actually,
the
if you do
times
that
have
in a
come.
very uncomfortable position, you will cause more astigmatism. I mean,
That is very true. But after so many cases, I found that all the positions are equally good for me. I mostly sit on the superior side. I do temporal incision from the superior side only, sitting on the head of the patient. So I don't feel uncomfortable doing these things. But I find that yes, even if 0.1 is reduced or 0.2 is reduced, I think it is better off, because the patient is not going for a toric.
Yeah, but if you're giving the incision on the steeper axis and you're not extending it, I mean, you're staying at a 2 or a 2.2 millimeters, like Dr. Ritu says, it doesn't really affect the astigmatism that much. Then it would make sense to extend the incision a little, I feel.
Yeah.
well, I agree with Dr. Ritu that sometimes it's uncomfortable going on the steeper axis. And previously, I also used to think that, but it's all the mindset. When you start doing in every axis, so gradually you become, comfortable in every position. But definitely, if you're used to temporal or superior position, that's always a more comfortable position for you. And marking the axis, why I mark it? Because pure temporal on the table is not always pure temporal or pure superior. So if you are a little away from the pure temporal and you're not coinciding with the axis, it creates, an oblique astigmatism. I have seen in my practice and my surgeries that the results have completely changed post-operatively after I started marking my steep axis and making my incisions on that.
One more thing, do anyone really looks up the surgical induced astigmatism, or arbitrarily they are saying 0.25 diopter? I don't think if you are making 2.8 millimeter incision or 2.8 millimeter another person is making, does it make any difference? The incision is same. So surgical induced astigmatism cannot be 0.25. This is, I think, absolutely wrong. I don't think you are doing something extraordinarily to make from 0.5 to 0.25 or 0.75 to 0.25. So actually this is, I think, arbitrarily anyone will boast of the thing that I am not inducing astigmatism, but specifically you are doing to reduce astigmatism, the other persons, they are not doing it.
No, sir, actually, sir, if I can just answer that.
Yeah.
Actually, see, it's not just the width of your incision, it's also the architecture of your incision, how much you distort it. You may be causing with your phaco, your technique of phaco. If you're causing a burn over there, you're distorting the wound, all that adds to the astigmatism. So when you are calculating your SIA, it has to be for a particular size, for a particular lens, and for a particular site. You have to at least have about 10 to 20 cases, and there is a format available online where you can enter your data post-op and calculate your SIA. I've done this a couple of times, and for each lens it would be different. So even if you're using an Alcon IQ and you're using a SP, your SIA would actually be different for both the lenses. So I think it's worthwhile calculating it. It's not very difficult actually.
No. Do everyone, does everyone doing it, or it's just arbitrary?
I think 90% of the surgeons are not doing it. Only 10% of the surgeons are calculating their SIA. And Dr. Ritu is right. The latest literature says that SIA should not be taken into consideration. But I feel it's a factor because most of the lens calculation asks for SIA. And you always tell them arbitrarily, okay, put 0.25, put 0.5. So I think you must know what is your SIA. That's a good practice to do.
Let's have one final word from Dr. Titial. I've brought him back to the meeting.
No, I think it's a nice discussion. As far as the newer considerations are concerned, because the incision has become 2.2 or less nowadays, the amount of induced astigmatism is negligible in those cases. In fact, newer formulas, they don't really consider SIA nowadays if you are doing a 2.2 incision or less. So it's become insignificant nowadays as such. If you listen to all the toric presentation now, nobody talks about SIA nowadays because not really going to make a difference. And I agree to Dr. Goel that many people would not actually assess because things have changed now. It was a real factor when your incision were 2.8 or bigger, but now incision become a 2.2 or less now, so it's become very insignificant. And what you do on the table, it doesn't translate subsequently after the patient covers 1 month or 2 months, because healing would have taken care of whatever change you have done it. So ultimately, SI is insignificant nowadays.
Yeah.
So Dr. Titial, you do predominantly temporal, or you go by the skin?
Yeah, I do 100% temporarily. That is a better position for doing phaco. You have a better access to the entire eye, and your both hands are quite stable because they have a better landing space area for your hand to adjust. Superiorly, sometimes very difficult, especially the deep set eyes, and getting into that plane of phaco is also difficult for superior. So in fact, all younger generation have shifted to temporal incisions. And now you have so many better, and cheaper toric IOs available. You can manage, these cases very effectively now.
So
during cataract removal, surgeons are managing.
Okay, I think you can say good night, Ajay.
Yeah.
So unfortunately, I have to,
Run.
just 1 second. We have to, there is a movie of Alcon that I have to show. Let me just show it. It's a very short movie.
It's a good night movie or what?
No, it's a small movie, sir. It's a good night movie for everybody about the Centurion. And before I do start that, let me thank all of you for participating in this meeting. And it's a real honor to have Dr. Titial. Thank you, Gaurav, for joining in. And I'm very happy that a lot of people are joining on the YouTube and Facebook, and we've had a good interaction. So I thank you all, and I thank Dr. Titial. We'll be having you again sometime in future. Thanks a lot, sir. So let me start.
I look forward to that.
Share my screen. 1 minute.
Okay.
Irrigation pressure and vacuum, and compensates for the pressure loss by squeezing the BSS bed more to help maintain the surgeon selected IOP. This results in a more stable internal chain. With gravity fluid air, since the fluid source may be bottom static.
Is it visible?
Chamber stuff. During cataract removal,
visible sound is less.
Since the fluid source is supply the interior chamber is much better able to maintain irrigation is initiated.
Let me
The eye will reach an IOP. Now, some surgeons use an air pump to achieve, for example, a bottle height of 95 centimeters of water creates 70.
I think I started it twice. Let me just
Yeah,
start
something
it
is
again.
going on.
Yeah. So let me start it again. So just 1 second. Let me
Dr. Tityal, can I ask you one question?
Sure, ma'am.
So now for toric IOLs, what is the kind of against the rule or with the rule astigmatism in which you would like to implant your toric lenses?
I think you're talking about a posterior corneal astigmatism, where
No,
it will make a difference what type of
Yeah.
with the rule against the rule astigmatism patient has, because
Yeah.
the posterior corneal curvature is always against the rule. So
Right.
if patient has with the rule, or patient has against the rule anterior astigmatism, the anterior corneal surface, then things will change. If both are against the rule, you're going to undercorrect the patient. If you have one is against the rule, one is with the rule, then you're going to overcorrect the patient. So in nowadays, if you have access to a OCT based system like IL Master 700, which gives a TK or a total K, which takes into consideration both anterior and posterior, it gives you a actual K reading for a calculation. But posterior corneal curvature is very little. It is range from 0.25 to 0.37 most of the time. So even unless you are doing a trifocal lenses, it may be of value. Otherwise, it doesn't have a significant value at all. So if patient has with the rule astigmatism, there you have to be little careful. The patient, most of our patients in this age group will have against the rule astigmatism. So it doesn't make a very significant difference in these cases.
So here you go. I'll share the screen. And is it visible?
Yeah.
Visible.
Okay.
During cataract removal, surgeons are managing irrigation, aspiration, and energy to emulsify and remove the lens. When irrigation is initiated, the eye will reach an IOP equivalent to the bottle height. For example, a bottle height of 95 centimeters of water creates 70 millimeters of mercury pressure. Different bottle heights result in different IOP levels. When aspiration flow occurs, the fluid movement results in a loss of pressure in the eye. Surgeons see this as a shallowing of the chamber and perhaps movement of the posterior capsule moving forward. With gravity and pressurized fluidics, the higher the aspiration flow, the more pronounced the shallowing of the anterior chamber. Flow changes occur not only by a surgeon's command of the foot switch, but also by varying levels of occlusion of the Phaco tip. The Centurion Vision System's active fluidics technology is able to detect flow rate, irrigation pressure, and vacuum, and compensates for the pressure loss by squeezing the BSS back more to help maintain the surgeon-selected IOP. This results in a more stable anterior chamber. With gravity fluidics, since the fluid source via the bottle height is static, pressure in the anterior chamber stability is dynamic. With active fluidics technology, since the fluid source is dynamic, the anterior chamber is much better able to maintain stability. Now, some surgeons use an air pump to achieve high irrigation pressure in the bottle, similar to a high IV port. This will generate a very high initial IOP value. That value will then decrease with flow. This is very different from active fluidics, where a much lower IOP value can be targeted and maintained.
So thank you very much. Thanks again to everybody for your active participation. And I think all the questions have been answered. If there's anything else which we can discuss, otherwise we'll say thank you all very much. Thanks a lot.
Thank
Good
you,
night.
Ajay.
Right.
Thank you.
Good night, everybody. Thank you, Ajay.
Thanks.